Deuk laser disc repair surgery for herniated discs at L3-4 and L4-5. This patient is suffering with back pain from the herniated discs along with leg pain bilaterally on both sides. So we're going to go on both sides because there's herniations on both sides, left and right. And our patient is awake, as they always are for the lower back and the thoracic. I'm going to start by injecting some numbing medicine. I'm going to give you some numbing medicine, okay? Don't jump off the table. It's just a little stick and burn. Okay, you're going to feel a little stick and burn. It's just some medicine going in. Don't get upset. This will help ease the pain for the rest of the procedure. Now, the patient needs to be awake for the beginning of these surgeries because I need their participation, getting down to the area that is a problem for the patient. All right, same thing on this side. You'll feel a little stick and burn. I apologize. I know that's uncomfortable. Just like when you go to the dentist, we put some numbing medicine in. We're doing the same thing here, just a little bit of numbing medicine. Except when you put numbing medicine in, it doesn't feel so good. It doesn't feel numb. It becomes numb. But it takes a few seconds to start working. All right, are you comfy? We're going to get started here. If you feel any pain, say ouch. Tell me if it's ouch in your back or ouch in your leg, all right? I don't expect you to have any ouches in your leg or back, but if you do, let me know. All right, so we're going to get started. This is a type of surgery that's done what we call transforaminal. Trans means across, foraminal means across the foramen. And our patient has herniated discs due to annular tears at L4-5 on both sides and L3-4 on the left. I'm on the left side currently. Yes, everybody agree? Yes, all right. So we're going to navigate. And navigation means just as you would think it means. It means to go from one place to another. And we're navigating from the outside world, where we are. Num num. I wonder if I should go a little bit lower as my starting point. Let's just see. All right, let me give some numbing medicine. So as we're doing this, if the patient feels discomfort as we navigate down to the spine, we want to give some medicine to make it more comfortable. And that's what we're doing. Okay, we're just giving you more numbing medicine. Relax, you're doing fantastic. So today we have 3 surgeries. This is the first of 3. You're doing okay. Shot. That looks pretty darn good, actually. You've done a nice job, Jordan, with 4-5. So I'm going to keep getting down to the L4-5. Just relax. You're okay. Everything's fine. Shot. And there's the facet. I need to be slightly lower and slightly more anterior. So I'm going to back up, aim a little bit lower and a little more anterior. Shot. You're okay. Just relax. Shot. Shot. All right, it's looking better. I'm hung up on the superior facet of L5. And now I'm around it. Shot. We're almost there. You're doing great, okay? Can you hear me? Shot. Shot. AP. I think we're a little off on orbit. You got to drop your hand. Now move it out. No, leave this here and move your hand out so you don't get radiated. All right, that's looking pretty darn good. We're right at the back of the disc at L4-5. You're doing great, by the way. What kind of tattoo is this? It looks like a baby dragon. Is that what it is? You like dragons? All right. Nothing wrong with that. You can feel the herniation. Where do you feel that? All right. Not down your leg. Okay. Huh? Oh yeah, don't move. You're fine. Everything's okay. This is the worst part of the surgery for the patient. Once we're done with this, you'll be fine. We're going to be able to put you to sleep. Not yet. You will soon, trust me. But right now I'm just getting everything in place to do your surgery. And that's why it kind of sucks for you, because it's not the most comfortable part of the surgery. I apologize. Shut. But it's necessary. All right, so how long have you had your back pain for? 2.5 years ago you injured it? Yeah. Where did you injure it?
When I fell, I ended up pushing my back.
You fell where? At work?
At work.
All right. Is it safe to say this is a work comp case?
It is a work. It is.
Uh-huh. Give me an AP. So we're right into the foramen now with the needle at L3-4. And I'm going to have you come south a little bit on your lateral, Jordan, just so we can see the sacrum and L5S1 to make sure we're at the right level. We're about halfway done right now, okay? And then I'm going to put you to sleep soon.
Okay.
Yeah, so lateral. So we're looking good. We're just entering the foramen. You can see the lateral part of the disc there at the tip of the needle. Show them the lateral part of the disc, Jordan, with the arrow. All right, don't move. You're doing great. That's correct. That's exactly where the lateral part of the disc is. You can actually see it there. That's the herniation. All right, come on back and give me a lateral view. All right, so where do you feel that?
In my leg and hip and back.
How far down?
My leg and my hip. Probably like right past my butt.
Did it go, what?
It left on my hip down into my, like below my butt.
But not past your knee.
I don't know, my knee blocked. Ow! Oh, no.
Just in your back?
The back and the left hip.
The left hip. Yeah, that's one of your bad discs. We're going to fix that. I apologize. I know. That's all done. You're okay. We got 2 of the bad discs already, and we got 1 more to go, and then we're going to put you to sleep, okay? All right. So the first part of these surgeries, these are endoscopic spine surgeries. And to do endoscopic spine surgery, you have to create a path, a safe path, to get the endoscope from the operating room to the tear where the herniation actually is. And that's what I'm doing right now. And that requires using, very thin, little skinny needles. I'm just going to give you some more numbing medicine, okay? I apologize. Yeah, I know. All right, we've given a total of about 8 cc's. Shot? Yeah, you can feel the fascia. Let's try to clean up the L4-5 just a little bit. I think it's a slight wag of about 1/2 degree maybe, and it may be some orbit, but let's just see what the wag does. So I'm directing my technician to fix the view with the x-ray machine, and he does that not by moving the patient but by moving the x-ray machine relative to the patient's body. The patient's laying still, and that really helps when the patient lays still, because That way we don't have to keep adjusting the x-ray machine. This machine we're using is a $180,000 machine. And basically what it does is it takes the very best pictures of the spine that you can get in the operating room and helps us navigate. That's, I think it's a little better there. Yeah, I'm okay with that. All right, so Jordan has basically lined up the L4-5 disc. This is bilateral 4-5. Everybody agrees? All right. Even the patient said yes. You're doing great. Just hang in there, okay? I'm going to put you to sleep soon, I promise. Shot? So my job is to get down to that disc and get into the tear. We literally enter the herniated disc through the tear where the herniation came out. And that's what... You're okay. Yep, you're doing great. We're almost there. Where do you have pain, Sean? Uh-huh. All right. Well, that's where we are. We're on the right side. We're almost done, though, I promise. You're doing fantastic. Sean? We're just skimming in at the bottom of the foramen. I want to be a little bit higher. Just relax. You're fine, Sean. If don't move around, you're doing fine. I know this is the worst part, but I need you to just lay still. You're doing good. Give me an AP. We're almost done. I'm like 95% there. That's okay. Hey, you're doing great. Listen to me. You're doing great. I promise. And literally, you've done fantastic. Just one little movement. No big deal. All right. Wonderful. So you can see that the right side needle is entering the foramen. You could tell based on the pedicle. You could see the pedicle of L4 and L5. And we're just on the lateral border of the pedicle. So you could see the bulging disc as well. You okay?
Yeah, it's just a shot.
Like I said, we're almost done.
Oh boy, okay.
Now I'm going to ask you a few questions.
Okay.
Like, I know you've had your back pain for 2.5 years since your work injury, right?
Yes.
What have you tried in order to get rid of your back pain?
They put me in physical
Physical therapy,
therapy.
pain meds, RFA, steroid shots, all right. Like epidurals? Yeah, it's epidurals. There's only really kind of one steroid shot. I mean, you can do a trigger point, but nobody does that really. All right, so you did everything but surgery.
Right.
What, because you didn't want to mess your dragon up?
No, that was gone.
So why did you put a baby dragon on your back? Because your back hurts? Or is your little baby dragon fighting your back pain for you?
That sounds good.
I like that, right? That's one treatment that I can't say I've ever seen. A baby dragon tattoo, so the baby dragon is attacking the back pain. Well, guess what? I'm going to join forces with your dragon today. And we're going to knock out your back pain permanently for the rest of your life. How'd you like that?
Oh, I love that.
People wonder why I can say that I can cure back pain.
Will I be able to go back to daily lifting weights?
Yeah, well, don't you get back to lifting weights too soon. You talk to me first, all right? All right. So people are amazed that I can say we can cure back pain because other doctors don't say that. The reason I can say we can cure back pain is because we've cured back pain. Thousands of times, literally thousands of times, me personally, with my surgeries. So after you cure somebody's pain, 2,000 or 3,000 times with different patients, you start to realize there's a method to the madness. And what it is that these disc herniations actually do cause horrible back pain or neck pain or thoracic pain because there's a little tear in the back of the disc. And that tear is called the annular tear. And the annular tear in the case of L4-5 is on both sides. And what's happened, she got the tear at work, doing a work injury. That trauma caused the tear. And as a result of that, the jelly now locked up in the center of the disc, can now squeeze out. Anytime she bends over and does anything minor, the jelly pushes out. We call that a herniation. Everybody's heard of herniation. Herniation means one tissue passes through another tissue that it's not supposed to be passing through. If your intestine is herniating through your inguinal canal, if you get a herniation down there in your groin, that means your intestine has pushed through a little passage in the fascia at the bottom of your belly. That's a herniation, okay? But it's an intestinal herniation. There's all kinds of herniations that can happen in the body. The disc herniation is only one type of herniation. That's why we call it a herniated disc, not just a herniation, because there's other herniations in the body. But this one happens in the spine, in the cushion between the bones. It's called a herniated disc. Now, when the jelly from the center herniates into the tear, it creates pain and inflammation in the tear. And one of the only tests in the world that tells us 100% whether or not this tear is causing her pain is something called a evocative or provocative discogram. Are you comfy?
Yes. Ow! It hurt!
How bad was that on a scale of 1 to 10? I'm sorry.
Oh my gosh, like a 12.
12 over 10? Okay. Now, for those of you paying close attention, I apologize. Just relax. It's going to get better in a second, okay? Well, we just tested your L3-4 disc, and guess what? It's definitely causing pain. Is that where you typically get your back pain?
I get it from head to toe.
Yeah, but I know. Is that where you typically get back pain?
This lower.
It's a yes or no question. Do you get pain in that area? Is that your typical area of pain? She's kind of a chatty Cathy. But basically, that was a 12 out of 10 pain. I didn't tell her when I was injecting. That's part of the test, is the patient shouldn't know. You comfy? Good. How bad is that on a scale of 1 to 10?
12.
Another 12 out of 10. Is that where you typically get your pain? All right. So yes. Concordant at 4-5 and 3-4. I have some great news for you. You get to go to sleep. When you wake up, your surgery will be finished, okay? I want you to count from 1 to 100 out loud so I can hear you, nice and loud. All right, well, she's counting, and we're putting her gently to sleep with the propofol and our anesthesiologist. I just want to reiterate what's happened. We have now accessed both discs with the needle through the foramen, so we've created a safe passage, but we've also gained access to the disc so we could do an evocative discogram test to see whether or not these two discs that I thought are causing all of her back pain, whether or not they are. And indeed they are. She had 12 out of 10 pain and 12 out of 10 pain. So you saw her when I injected, she almost jumped off the table. Hopefully you guys could see that. You could hear it through the microphone a little bit. But clearly these two discs are definitely causing her back pain. And knowing that, I know that when I go in there and fix the tear in the back of the disc, that we're going to get rid of her back pain. We're not going to take her whole disc out. We're leaving the disc there. We're just debriding the tear and removing the herniation that's inside the tear and outside the tear. There's two parts of the herniation. Marking pen. There's the part of the herniation that's stuck within the tear, and there's the part of the herniation that is outside the tear. So let me show you, because this is very important. Can you all see this? Can you all see this disc?
Yes, we can see it.
All right, so there's a wall here that's made out of collagen on both sides. Is she asleep yet? And what happened is trauma, like an accident. You have the nucleus pulposus or jelly here, and then you got this thick wall called the annulus fibrosus. And people get a tear in this wall, and then the jelly from the center pushes into the tear and out of the tear. There's two parts, this part out here and this part of the herniation that's inside the tear. They're very different. The part out here creates inflammation on the nerve root. The part in here creates inflammation within the annulus fibrosus. And a lot of people don't know this, but the outer half of the annulus, this outer part, actually has pain fibers in it. So that if you create inflammation in here, you're going to feel it as back pain. And that's exactly what causes the back pain. That was discovered here at Duke Spine Institute by me about 15 years ago. And I published our results of debriding the annular tear, the first in the world to debride the annular tear, and the pain goes away, whether it's in the neck or the back or the thoracic. Same thing happens. That is the source of the back pain. And again, we're the ones who discovered it here at Duke Spine Institute and published it back in 2012. All right, so first thing I'm going to do is treat the L4-5. We've got our guide wire. We're going to take the needle out. Let's get a shot. So I got to get this needle out without taking out the guide wire. I've placed the guide wire through the needle, and you can actually see the guide wires inside the disc at L4-5, and that's going to guide my surgical tool. The next tool that I'm going to put in is going to be guided with the guide wire. By the way, you see the incision is 7 millimeters. Can you see this here, Diego?
Yes, we can.
That's a Band-Aid incision. The whole surgery is done with a Band-Aid incision because it's done endoscopically. So here's the first instrument that's going to go over the guide wire. It's called the dilator. All these stuff are FDA approved, by the way. This entire surgery, everything we use is FDA approved. Shot. So you can see the dilator is now coming down the guide wire. The tip of the dilator looks like a pencil, but it's not. It's a metal instrument, and it's tapered. So what tapered means is instead of damaging tissues, it spreads them apart, okay? So when something's tapered, put your hands together. Put your hands together. Not hard. When something's tapered, it gets between tissues, fibers, and pushes through, like my hand is pushing through, and that causes the tissues to spread. And while this thing is in here, the tissues stay retracted. Because we're going to put a tube in there, you'll see it's going to hold the muscles and fascia apart. And then when we're done, we're going to take everything out and the tissues come back together. So there's no damage to the actual tissues inside the body. This is in stark contrast to all open spine surgery. Microdiscectomy, laminectomy, fusion, artificial disc, foraminotomy, everything else done in spine surgery except for endoscopic transforaminal surgery is highly damaging to the body's tissues inside. You just don't see it, but you experience pain after surgery. And these patients don't have pain after surgery. That's why we give them Tylenol for pain, because the pain is mild to minimum. Whereas with open spine surgery, it's horrible pain. You're going to take narcotic painkillers for like weeks. Okay? All right, we're going to go ahead and advance the dilator now through the tear in the disc. She's a little more responsive than I want her to be. Just lay still, you're fine. So we're going to put her a little bit deeper because this is the painful part of the disc. Just lay still, you're doing great. Because this is the painful part of the disc, the outer part where the inflammation is that's causing her pain, it's going to be the more painful part of the procedure, which is why we put our patients to sleep. But asleep obviously requires monitoring to make sure they stay asleep. And as we advance through the tear, that painful tear, the patient, if they're not asleep enough, they'll respond. And that tells us we need to give them more anesthesia medicine. So that's what we're doing right now. We're just waiting. I'm waiting for my anesthesiologist to get the patient more asleep. Any questions from our audience?
Yes, our first question comes from Facebook. How long will this procedure last?
So the question is, how long will the procedure last? I assume what the question is how long will it take me to do the procedure? Usually it takes about an hour to do the procedure, maybe an hour and 15 minutes for 3 levels. It's about 30 minutes per disc level. So we're doing 1, 2, 3. So it's really about an hour and a half total time. That's average. Great question. So we're going to run a video for you right now to show you why do herniated discs cause back pain and even leg symptoms like leg pain. Are we ready? Diego.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc,
You're alive.
All right, Dr. Deukmedjian here again, and hopefully you understand a little bit more now after watching our animation video that annular tears can become inflamed, and when they're inflamed they become painful. So what causes that inflammation is the actual herniated disc, the herniated nucleus pulposus, the jelly from the center that is pushed through the tear. Why don't we show people what we're going to be doing here with the laser in just a moment. Let's show the animation that demonstrates and explains what we do with this Deuk laser disc repair procedure. Sean?
common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for...
Okay, we're back here doing the surgery, and I just want to show you a couple of things. Number one, look how small the incision is being done. This is not an incision for a microdiscectomy, laminectomy, fusion, or even an artificial disc or an XLIF. All of those incisions are much bigger. This is the smallest surgical incision possible in the human body for minimally invasive spine surgery. And that's because what we're doing is true endoscopic spine surgery. Not the stuff that you hear about elsewhere where they say it's endoscopic and it's really not. Everybody wants to do, all the surgeons want to do minimally invasive spine surgery, but the reality is they're not doing it. They're just pretending to do it, but there's a few surgeons in the world that actually know how to do this type of endoscopic surgery, which is the best, but it's also the hardest to do. You have to be trained properly to do it. I had to go overseas to learn how to do this because it wasn't really being done in the States, and then I picked up my education here with Dr. Anthony Young, who did it in Phoenix. He's now retired, but he trained me as well. So the opportunities for training are very small, very few, and there are thousands of spine surgeons who are untrained on this technology still. Someday they may be. All right, we're going to go in and fix the L4-5 disc on the left side. First, we're going to use this tiny tube, it's 7 millimeters, and we're going to use the endoscope. The endoscope is this structure here. Can you guys see this?
Yes, we can see it.
So this is an endoscope, and it has a portal where I can actually work through. It's got a light source and a camera, and I could take that camera and that light source and I could project the image of what I'm seeing at the end of this. Remember, we created a safe portal to work through, right? That's what we did in the beginning when I used the needle. The whole point of putting the needle in with the patient awake was to create a safe passage. down to the herniation. This is the herniation right here. We're going to start taking it away using the laser. That laser thing, that little glass pipe at the top is a laser fiber. It's glass. And what it does is it basically takes the laser energy, which is created by a machine here in the operating room that's about as big as a big suitcase, and that laser machine creates energy that is delivered now to the end of this little tube, this glass pipe. Okay? And that's what you're seeing. The laser is emitting energy, and I'm removing, vaporizing, breaking up, destroying this bad tissue here that's not supposed to be here. This is the herniation. Now we call this the annular debridement because I'm removing the herniated fragments out of the annular tear using the laser fiber. Okay? And you've already shown the video on what happens here, right, Diego?
Yes, sir.
Yeah.
We do have another question.
I'll take the question.
Yes. Someone's asking, may a family member spend the night...
Diego, you're moved your mouth away from the mic.
May a family
cannot hear
member
you.
spend the night with me at the hospital?
Once again, you are totally inaudible.
Can you hear me now?
I barely hear you. Is there a way for you to set your mic so that it's consistently the right volume?
Doctor, can you hear me?
It's too loud.
All right, how about now?
That's good, Diego.
Okay. They want to know if a family member can spend the night with me at the hospital.
If a family member can spend the night with you at the hospital.
Yes.
All right, great question. So the most important thing that I didn't mention earlier is that we don't do these surgeries at the hospital. This is an outpatient procedure. We've been doing them now outpatient for 15 years. There is no hospital. We've never taken these patients to the hospital. These are all outpatient surgeries. So there's no need to stay in a hospital. This patient's going to go home. There's a herniated fragment right there. It just came out. This patient's going to go home in about an hour after their surgery. It takes an hour to recover. The average recovery time is 52 minutes. That's just under an hour. And then the patient's going to go home with their family member who will drive them. If you're from out of town, you go to the hotel and you spend a night in the hotel. You come back here in the morning, we check up on you, and then you go back. You can fly back home wherever you live. Most of our patients are from out of state. They fly to Orlando, Florida, and come to Duke Spine Institute. How's she doing? I've got the fiber back in, Yeah, I don't know if that helps, but none of these surgeries are done in the hospital. The hospital is in a relatively dangerous place to do surgery that's elective. Why? Because number one, they don't have anything better than we have in terms of equipment or staff or training or medications or anything. We actually have better equipment, better staff, better drugs, better supplies than the hospital at Duke Spine Institute. And these surgeries don't require a hospital stay, so why go to the hospital? Unfortunately, the hospital is also where you get COVID or other bacterial infections. They're called nosocomial infections. So we don't want to go to the hospital because we don't want to expose our patients to the risk of infection. Then the other thing at the hospitals is that hospitals have been cutting costs so much over the last 10 years to try to make more profit or at least stay in business. And in that cost-cutting attempts, they've compromised quality of care, undoubtedly. And I know this because I've worked at the hospital for, I still have staff privileges at 3 hospitals, and I've worked at hospitals for about 25 years. So I know that every hospital across the country is trying to save money and cut costs. They don't buy the newest equipment, many of them, that's needed to do the surgery safely. And they, unfortunately, will even go so far as to have nurses do the anesthesia, which I don't agree with. But at the hospital, you have no choice. You have to accept whoever they give you. And I believe that we should be using medical doctors, not nurses, to do anesthesia. That's my own personal preference. I know that if I was having a surgery, I want a medical doctor there supervising my surgery. So medical doctors cost more money to be there, but it's worth it for the safety, for the patient. How are we doing over there?
Doing good. I had to turn her down a little bit, but she's doing good.
Yeah, I mean, once I get past the tear, the most painful part, and I get inside the disc and start removing, she can wake up a little bit. Now this is very scarred up in here. I can see how much scar tissue there is. All this is scar tissue from chronic inflammation. So the herniations occurred about 2 years ago. This injury looks like it is about 2.5 years old to me. From all the discs I've looked at over the years and knowing how old the injuries are, I can usually tell if the disc looks on the endoscopic view to be about the age of the injury, and it does. Remember, most herniations, though, are multi-step things. They don't just happen once. Once that tear occurs and you get the first herniation, that inflammation it creates within the annular tear weakens the annulus even more and creates more herniations. So the disc is more likely to herniate after the first herniation. And that's why people get episodic pain from herniated discs. They'll get a little bit of pain and discomfort. It'll get better as the disc settles down and the inflammation dies down a little bit. And then the pain will get worse again once they do something strenuous and they create a little more herniated material into that tear, which reignites the inflammation. So what would be the alternative surgery to this? Well, if a patient has just leg pain and no back pain, then a microdiscectomy is the most common surgery done. Let's run the microdiscectomy video. Just cue it up for me, and then I'll tell you when to run it. I want to make a few points. Let me know when you have it queued up, Diego.
It's ready when you are.
All right. So microdiscectomy is a 100-year-old procedure that spine surgeons are taught to do as their bread and butter procedure for a herniated disc in the lower back. The herniated disc in the lower back, only when it's big enough to cause leg pain or weakness in the leg do you do a microdiscectomy. We call that weakness or numbness something called radiculopathy. Radiculopathy means a problem with the nerve root. So when you have a large herniated disc in the lower back and it causes leg pain or weakness in the leg, you can do a microdiscectomy. Microdiscectomies do not fix back pain. They only fix leg pain. They're not done to cure back pain. So a patient with back pain, which by the way happens to be about 99% of patients with a herniated disc, their back pain doesn't usually get better with a microdiscectomy, and the surgeon doesn't do a microdiscectomy to cure the back pain. If you don't believe me and you have a herniated disc in your lower back and you've got leg pain, ask your surgeon, will my back pain go away with this surgery? They will tell you no if they're truthful with you, okay? Now, once in a while they get lucky and somebody's back pain does get better. But with this surgery you're watching now, we get rid of back pain. That's one of the main reasons to do the Deuk laser disc repair is the back pain, not just the leg pain. So this procedure gets rid of the back pain because we're debriding the annular tear. It gets rid of the leg pain because we're debriding the annular tear and decompressing the nerve root. But just for comparison, I'm going to show you a microdiscectomy here. And I want you to pay attention to a couple of things. Number one, when you do a microdiscectomy, you have to first of all make a larger incision on the skin. So there's a bigger scar and more bleeding. You have to actually scrape the muscles off the bone, and that causes permanent damage to the muscle. And if you look at an MRI on a patient who has a microdiscectomy, you're going to see that there's actually scar tissue where the muscle used to be, massive scar tissue. Why? Because the muscle was destroyed during the surgery. It's always destroyed during a microdiscectomy. Surgeons don't tell you that, but that's exactly what happens. Why don't they tell you that? Because it's basically impossible to do a microdiscectomy without damaging the muscles and causing scar tissue. So it's just part of the surgery, you know? So they don't bother to tell you about it because everyone does a microdiscectomy and there's just no way around it until now with the Deuk laser disc repair, where we can actually not damage the muscle. We can go from the side. A microdiscectomy, you're also going to see, requires drilling a hole in the bones of your spine. Making a hole in the bones of your spine that are normal bones, that's bad. That's just going to weaken and destabilize your spine. And then you got to remove ligaments too, and you're going to see the ligaments being removed in this animation. That ligament is called the ligamentum flavum. And the ligamentum flavum is a stabilizing ligament. It actually holds the bones together in your spine, but it's being removed during a microdiscectomy, okay? And of course there's a lot of bleeding during a microdiscectomy. You can see with this surgery I'm doing, there's no bleeding. We've lost a few drops of blood, that's it, less than 1 milliliter. So compared to the laser surgery, a microdiscectomy is a much bigger incision, more scar tissue, damage to the muscles, which causes more scarring and postoperative pain, and the need for narcotic painkillers. Also, you have holes being drilled in the bone and ligaments being removed, so that weakens and destabilizes the spine. And then finally, the most important thing is when you get to the herniation, you're not really debriding the tear in the annulus. All you're doing is taking out a little bit of the herniation, not all of it. So you actually leave herniation in there, so the tear in the back of the disc never actually heals all the way, like it does with the laser surgery that I'm doing. So this surgery is the only surgery that actually allows the disc to heal properly after surgery, because we're cleaning all this junk out in the tear. Right here is what I'm doing. Removing all this herniated blue stuff is the herniated disc. I'm removing it with the laser and cleaning the tear so it'll heal. Once this tear heals, then the disc won't reherniate and it won't degenerate any further. All right, let's show them our microdiscectomy animation so they can see what I'm talking about.
Okay, Deuk, you are muted and they're watching the video.
Okay, thank you. Good job, Diego. How's the sound, Sonny?
A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have
All right, Dr. Deuk here. We're just about done. I want you to look. See those little white fibers back there? Those are going to be the beginning of what's called the posterior longitudinal ligament. It means we're pretty darn close to being done with this disc in terms of debriding it. And there's the epidural fat right there. That's going to be in the foramen, in the epidural space. It's what's called the spinal canal. That's the end of the foramen where the foramen ends, right there. So we're pretty much just cleaning up the last bit of the annular tear. This is the debridement of the annular tear with the laser fiber, the blue thing. The blue is just plastic over the glass pipe. The blue is just a plastic covering. It's not the actual glass. The glass sticks out of the blue. You can see it right here. It's a 0.5 millimeter wide, but that glass tube actually transmits the laser energy through a process called internal reflection or refraction, where the laser energy bounces off the walls of that glass tube. I was watching a program on TV the other day about how the fiber optic transatlantic cables are made to transmit broadband across the ocean, undersea. And of course they use, this type of a glass tube, but a much higher quality glass tube, basically. And I was watching how they make it. They actually heat the glass up and then drop it, I think 140 feet down a tower, and it just stretches into a uniform thickness glass tube. And then they cut it and test it to make sure that the glass tube can transmit the signals, the broadband light signals, laser signals basically, properly. And if they don't transmit it efficiently, I bet you they sell it to people like us where we use it for laser because the application here of that glass tube it doesn't need to be as high quality as broadband signaling in the transatlantic cables. But they don't want to throw it away either. But it's good enough for laser spine surgery. All right, any other questions?
No questions, but we do have a commenter that said that they just submitted their free MRI review.
All right, very good. Yeah, thanks for bringing that up. Why don't you put up a link? Deuk Spine Institute does free MRI reviews for people around the world. There's no obligation, there's no cost. We do it to help people. Why do we do it? Because there's so many doctors out there that honest to God don't know how to make the right diagnosis, what's causing someone's back pain or neck pain or thoracic pain. And so people are condemned to live their life in pain. And that just doesn't sit well with us at Deuk Spine. So we at least want to give people the opportunity to learn about why they're having pain, and then of course what treatments are available. And then if they can get it fixed, great. If they can't, then maybe someday they can. But at least they understand and they have hope that there's a way to get it fixed. And they don't live with misinformation that it's not fixable. Okay, just about done here. Yeah, I know, we're almost done. There's a piece of herniation right there. That's what I'm trying to take care of. Then you got a little bit of adipose tissue billowing out. Yeah, we're fine. A little more herniation there. Yeah, this is going to be the more painful part of the disc too. Anytime you're near the outer part of the disc, that's where it gets uncomfortable because that's where the pain fibers are. Remember, the outer half of the annulus is where the pain fibers are. So we're in the outer half of the annulus for sure. We're on the surface of the annulus right now. And I'm just cleaning up the herniations that are here laterally and superiorly. Remember, we're penetrating the annulus in a specific location, but there could be tear going up towards the head or down towards the feet or lateral towards the flank. I've just got to make sure we get it all. I'm looking laterally right now, right there. All right, so that's it. I don't see any more tear. It looks good. Maybe clean this up a little bit more here. That's all part of the nuclear material that's stuck in there. I get the question quite often, how do you know when to stop, you know? And I don't know. I think when I created enough debridement, like when I start seeing the posterior longitudinal ligament fibers, for sure, there's really not much more you can do unless you've got herniated fragments above that, in which case you have to go above it to get them. But generally a bulging herniated disc like this is it. You know, once you start getting the fatty stuff, you know, if you don't want to go more medial, because medial to this at 12 o'clock, you're going to have the traversing root. And you don't want to damage that with the laser. So it has to stay behind the retractor where it's protected. And then at 9 o'clock over here, you have the exiting root. So you have the exiting root right there, just on that side of the metal, and you have the traversing root at 12 o'clock. So we're right between the two, and it's a place called, you can look it up on the internet, Cambin's Triangle. It's named after a surgeon named Parvis Cambin, who was an orthopedic surgeon. He was the first one to discover this area of the spine and how you can work through it transforaminally to repair disc herniation. So he's credited with naming it after himself. Cambin's Triangle. Look it up. It's called the Safe Zone or Cambin's Triangle. All right, we're done. I'm happy with that. Actually, let me get just a little bit more. Sorry. Thought we were done, but what happens sometimes when you think you're done, the roof kind of comes down a little more, it settles, and you see a little bit more of the herniation. And I want to make sure I get as much out as I can safely. How's she doing? All right. Any other questions from our audience, Diego?
Yes, we have a YouTube comment that wants to know what medication will the patient take after this surgery.
Great question. Because it's minimally invasive, they will take Tylenol, and we give everybody a muscle relaxer in case they get some muscle spasms. Most people, about half the patients, need to take the muscle relaxer that night, and then they're done by the next day. We call that muscle relaxer Flexeril. But there's no narcotics given, just anti-inflammatory and a muscle relaxer. So this is a no opioids, no narcotic, very safe surgery. That's it. All right. And literally, people come in and they tell me the next day, oh yeah, I took the medicine, the Tylenol and the muscle relaxer last night, but I only took it one time and I don't need it anymore. So this is the most pain-free spine surgery in the world, because all other types of spine surgery, that people need to take Percocet or morphine or some type of an opioid afterwards, usually for at least a few weeks. That's one of the reasons why Workman's Comp really likes this surgery, is the minimally invasive, fast recovery, and no narcotics. And by the way, patients can go back to work literally the next day, as long as they do light duty, you know, because you're not on narcotic painkillers, and you have only lifting and bending restrictions of 25 pounds lifting restriction and no bending at the waist. So they could go back to a desk job and work, you know, and they're not on painkillers, so they're not messed up in their heads, you know, with narcotics. Here. All right, one down, two to go. So I'm going to now remove the tube, and we're leaving the other needle in there because we still haven't done the L3-4. So usually what bleeds is the muscle, if you get a vein, like a little vein. So I like to apply pressure for a few minutes to the muscle, just let it stop bleeding. Come on in. Our blood pressure is perfect. Yep. So I'm going to bring the fluoroscope back in. That's the x-ray machine. I need to use the x-ray machine to place the next, to fix the next disc, to place the next tube, so I could work through that tube. So the tube that I had in there was at the L4-5. That's the bottom disc of the two that we're fixing. Now, can you redo that, please? Come on. Now I'm going to work on the L3-4. Look at the herniation at L3-4 on the x-ray. Show them the herniation. You can actually see it bulging back because we put the dye in there. That's correct. You see that kind of curvature? That is the herniated disc at L3-4. Let's show them the sacrum. Show them where the sacrum is, the sacral bone. You see how it's one long bone? Show them the L5-S1 disc. Yeah, that's L5. There's the L5-S1 disc. Correct. We're not operating on that. That's normal. And let's go up. And that's L4-5. And then let's go up. That's L3-4 disc. And we're going to be fixing that herniation next. Okay. So I'm still applying pressure. And if you want to do this kind of surgery on people's backs, remember, they've got huge bands of muscle back here. And we went through that muscle using the dilator. Can you see this?
Yes, sir.
So we split the muscle. We didn't cut it. We split it, and we went in, and then we put the tube over that, and we took the dilator out. So we were left with a skinny tube that looks like a straw. We're going to do the same thing now. So here you go. First, I'm going to place the guide wire, Raytech, which I did. Now the guide wire is this thing, and it goes through the middle of the needle. Once I get it all the way into the disc, shot. Next I can take the shot, I can take the needle out. Shot. And you can see the guide wire right there at L3-4. I'm going to take the needle out and leave the guide wire anchored inside the disc. Now remember, this needle and guide wire are passing through the tear that the disc herniation came out of. Okay, shot. So now we have the guide wire, the needle's gone. You see how skinnier it is? We're going to bring the dilator down over the guide wire. See this here, folks? Take a look. Show them the incision. That's a 7mm incision, Band-Aid incision. The whole surgery is done through that little guy. All right. Now I got to bring this dilator down through the fascia and the muscle and any other soft tissues like adipose tissue to stay politically correct. All right, so now the dilator is right up against the herniation. Okay? And now I got to go, I'm going to go through the tear that's already there. So the annulus was torn, it created a herniation, and I'm literally passing right through the herniation. I'm not damaging the normal disc anywhere. I'm not damaging the normal parts of this disc. I'm literally passing through the herniation itself. And I'm going to shove part of it back inside the disc. She's responding a little bit, but you know what? We're going to be done with this in just a minute, as long as she's comfortable. Shot. So we're entering the disc. I take the guide wire out. I want to make sure my dilator is all the way in. It is. Now sometimes the dilator will get pushed out because the intradiscal pressure is so high from inflammation. And remember, inflammation causes swelling. So if you get swelling inside the disc, it can put pressure. And that also contributes to patient's pain. So that can actually push your dilator out. I've seen it happen several times. Shot? Yeah. A little bit further. Shot? That's good. All right, we're in, like Flynn, we're inside the disc. Let's get the fluoro out. We're done with that for now. We're very conscientious about how much fluoro we use or x-ray we use. We want to use the least amount possible. So with these types of surgeries, we'll use about 15 seconds of fluoro, 15 seconds. All right? And if you do an open surgery, you're going to use about 2 minutes to 3 or 4 or 5 minutes of fluoro. And that's a lot more fluoro, X-ray radiation, when you do open spine surgery. So it's much less invasive and much less fluoro. Shot. I mean, I need to see the camera view, guys. Come on. Let's put our thinking caps on. All right. We are literally inside the L3-4 disc, inside. And that's what you're seeing there. That tube around me, that is that straw-like tube you're seeing called the dilator. Now look at the pinkness of that tissue. There's some inflammatory changes in there. And inflammatory tissue is red, pinkish red, because it has a lot of blood flow. That's herniation right there, the blue stuff. My dye that I use stains the herniated nucleus pulposus blue. That's why it appears blue. It's the only surgery that does that. Endoscopic surgery. It was a technique taught to me by the South Koreans and by Dr. Anthony Young. Was to use a vital dye that stains the degenerated disc blue. It's not my brainchild, but it's something I learned from my teachers who've been doing this longer than me. All right, that's the annular tear and part of the herniation right there. It doesn't want to come out so easily, so I gotta release it using the laser because it's stuck to the annulus and it doesn't want to come out. What causes it to stick to the annulus? Anybody know? Scar tissue, right. Why is there scar tissue? Inflammation. Why is there inflammation? The annular tear and the herniated disc interact together to make inflammation. All right, standby grabber. You got to hand me the grabber the right way, yes, which is doesn't require me to reposition my hand.
Makes sense.
It gets all right. So one of my former friends reached out to me by Facebook today. And I knew her from UC San Diego, where I went for undergraduate, University of California, San Diego. And she reached out to me from Seattle, where she's living. And yeah, it's pretty cool. She found me on Facebook. I'm sure a lot of people see their old, college friends. That's pretty cool.
We have a new question from Facebook.
Sure.
Yes. How long after the surgery does PT start?
How long after the surgery does the physical therapy start?
Mm-hmm.
It starts the next day, same day or next day. If you have surgery in the morning, it starts that evening. Basically, you're up walking, and I want you to do a 20-minute walk with your back brace, starting that day. If you can do it, most people can. And then every day you're going to be doing your own physical therapy by walking, 20 minutes twice a day, morning and evening. I tell people for the first 2 weeks after surgery, don't go over 30 minutes. So it's 20 to 30 minutes for the first 2 weeks every day, twice a day. Then you're going to have physical therapy with what's called supervised physical therapy with a therapist, either a chiropractor or a physical therapist that knows what they're doing when it comes to recovering white patients that have laser surgery. And that requires two things. And this is what a lot of people don't understand. If you go to the wrong physical therapist after laser surgery like this, they may actually have you do something you're not supposed to do. They may have you bend at your waist or bend your legs up towards your head, and that could actually ruin the surgery we just did. Has that happened to me before? Absolutely. It's happened before. I've had patients that had this laser surgery and their pain went away completely. They were doing fantastic. And then they went to therapy and the therapist told them, hey, you need to bend at your waist. They've even said to the therapist, no, I'm not supposed to. Dr. Deuk said no. And the therapist would say, hey, Dr. Deukmedjian's not a physical therapist, I am. I know what you need to do. And that's correct. I'm not a physical therapist, but I am a surgeon. And surgeons do have the ability to give restrictions after surgery to their patients. And therapists are supposed to respect those restrictions. The problem is some therapists don't, because they think that they know more than the surgeon does, which they do when it comes to physical therapy overall. But when it comes to actually doing physical therapy on a patient that just had surgery, the therapist is supposed to listen to the surgeon and not blow off the surgeon's restrictions. And unfortunately, it does happen, where the therapist ignore the surgeon's restrictions and put the patients through a therapy routine that would be fine if the patient didn't have surgery. Does that make sense? So the therapy is very important after these types of surgery, and it has to be done properly. But it's not just important to get the patient to do therapy, but it's also important to get the patient not to do therapy that will hurt them. And that goes beyond the therapist's office too, because people do things at home. Like I had a guy from actually from Seattle, where he came out, and this was years ago. He had the perfect surgery. Come on, man. Stop doing stupid things. Where he had the perfect surgery. He did great. 2 weeks after surgery, I have no idea what he was doing exactly, because he wouldn't tell me exactly. I think he was embarrassed. But he was doing something with a car where he was lifting the car up. Okay? Lifting the car up. Like picking it up. And felt a pop in his back, and then of course he re-herniated. And he told me the truth. He was a bit embarrassed, and he came back and had the surgery again, and it worked. And people do things after surgery they're not supposed to do. So the therapy does two things. Number one, the good therapist will tell you what you should do, and how many times you should do it a day, and the proper way of doing it for therapy. But they also will tell the patient what not to do, so they don't get injured. They don't ruin what was just done. Okay? And that therapist for us is Florida Sports and Spinal. So it's a group that we work with. They are down the road from us. They're a separate business than us. I have no venture or stake in it. Hey, how are we doing on irrigation? Because it's looking a little sluggish. Huh? Hello? The irrigation's looking sluggish. Why are you waiting? You got to pay attention to that, and so that you don't make me stop what I'm doing, so I can tell you. You've got to be paying attention. All right, thank you. All right, well, I guess I usually wait because there's a dry moment where there's no irrigation when you switch bags, but I guess that doesn't happen with this, Luis? Do we not get the dry moment anymore? No, we don't, or you don't know? So we used to get a dry moment, right? When there was a... I didn't see. No, I didn't see it. What do you call it when there's no water? A drought. There's normally a drought, but we didn't get the drought with the bag switch, so that's good. I guess because of the pump, right? So I was just talking about therapy. Yeah, you like the pumps. Did we get a third one?
It's on the way.
All right. All right, good. So we were talking about post-operative therapy for these patients. All of them need post-op therapy, but there's two types of therapy. There's self-guided therapy where you do it yourself without a therapist, like walking every day, 20 minutes twice a day. You don't need a therapist for that. And then you have supervised therapy. And the supervised therapy is important because for two reasons. Number one, they tell you what exercises you should be doing to strengthen your back, but they also tell you what you shouldn't be doing. So it's kind of a two-edged sword. You've got to not just do the right exercise, but you also have to avoid things that will hurt you if you've had this kind of surgery. All right, am I rambling on too much? I'm surprised. If you look at the MRI, this disc doesn't look that bad. But now that I'm inside the L3-4 disc, I can see how much damage there was. It was massive. So this is a great example of how an MRI doesn't really show you the whole picture. This MRI of this disc, I mean, show them the MRI, Diego. You go ahead and bring it back up at L3-4.
Yes.
Honestly, it doesn't look that bad, but look at all this herniation, the blue here, the scar tissue here. There was huge injury to this disc, like huge as in volumetrically huge. A large volume of the disc was injured, and I can see that endoscopically, but you cannot see that on MRI. I only mention this because I've seen this many, many times. The MRI is completely unreliable in terms of telling you what the problem is with a patient. You cannot rely exclusively on an MRI, whatever you do. I get people all the time who say, oh, my MRI shows 2 herniated discs. That's all I need fixed. Well, maybe, maybe not, It really takes the physical exam, looking at where the pain is, along with the MRI, possibly a nerve test, and possibly some additional tests. But I've been doing this 25 years, and honestly, I don't think there's anybody, I don't know of anyone in the world that is better at figuring out where people's pain comes from than I am. And most people aren't even close. They're not even in the same zip code. And I can tell you that how many times the MRI can fool you because you think that the MRI is showing you where the problem is, and it's not. The patient's pain isn't even remotely close to where the bad discs are. Or the disc injury may be subtle on the MRI, but it's actually on endoscopic view, it's massive. Massive. That's one of these right here. I would never have ascribed this much internal damage to the disc based on that MRI image at L3-4. See what I'm talking about, Diego?
Yes.
How are we doing over there in the control room, Diego?
We're doing well.
Look at this. Look at this, just destruction. This is way lateral in the disc, way off to the side. And the problem is if I don't treat it and I don't debride it, it's not going to heal properly. So I have to treat it. Even though lateral part of the herniation rarely causes pain, it could create a problem over here in the part of the disc that does cause pain. So I've got to treat it all almost equally so it heals properly. If you leave the lateral herniation and the lateral tear untreated with a laser, then you're going to end up reherniating more easily. So that's why I always treat the lateral along with the medial, the part that's closer to the nerves. This is all damaged disc. This whole thing is just incredible. Again, the MRI did not let us see this. And that's a good MRI, by the way, a good quality MRI. Nothing wrong with it. Laser, come on. Piece of herniation there. Just about done with this disc. And of course we've got one more side to do. That'll be the L4-5 on her left. Her right. Because currently we're on the left right now.
I don't hear.
Any questions?
No questions, but it looks like there's a patient of yours in the chat that just got a free MRI Zoom call with you.
Yep.
He got injured his back doing stunt work.
Oh,
Mm-hmm.
all right. Yeah, I kind of remember. I think I remember talking to that person.
Yes, he said that he knew Evel Knievel and
Yeah.
jumped motorcycles off a ramp and
That's
broke
right.
his back and neck.
Yes, I remember you. We talked.
He said that many people have worked on his back, but you're the only doctor that he trusts today.
I appreciate that. Thank you very much.
Mm-hmm.
Trust is important from somebody who does stunts like Evel Knievel. How many people remember Evel Knievel and his legacy? I do. I grew up in the 70s and Evel Knievel was all the rage. I remember just as a kid wanting to watch him do his stunts, you know? And that was a really big thing back then. Of course, that was back when we didn't have Facebook or social media. It was just television. And yeah, anytime Evel Knievel was doing a stunt, the whole world kind of stopped what they were doing and they watched. I remember the first time I saw Evel Knievel, I was just a kid. I think it was probably about 7 or 8. And I remember saying to my dad, "Hey Dad, why is Elvis Presley jumping a motorcycle across the Grand Canyon?" Right? Why is Elvis Presley jumping a motorcycle across the Grand Canyon? I'm sure my friend over there will get a kick out of that one. All right, just about done. And then we'll switch sides. This, like I said, this disc herniation is a lot worse inside than you could tell on the MRI. I can tell you right now, 99% of spine surgeons, spine doctors would have just blown this disc off. They would have just left it alone, and this patient would have pain here for the rest of her life. The pain is debilitating. You saw it was a 12 out of 10. Okay? And they would have left it alone. And this is happening all over the world right now, today. It's been happening. It's going to happen, by the way. It's going to keep happening. Why? Because people don't know any better. They think little herniated discs can't cause problems, but they can. And the reason they think they can't cause problems is because they don't see any nerves getting pinched. So they say, oh, the nerve root's not getting pinched, so it can't possibly be causing pain. I can't even begin to tell you how misguided that is. It's like so wrong. Nerve roots don't cause back pain or neck pain when they get pinched. They cause arm or leg pain, not neck pain or back pain. So all these doctors are like, we don't know what's causing your back pain. It's probably in your head. Just take pills, you know? When the reality is the cause of the back pain is right here. It's this tear. They just don't know that. So guess who pays the price for ignorance of the doctors? The patients do. The patients do. They live with back pain and neck pain every day, and it destroys their lives. It robs them of their dignity. How do I know this? Because this is all I treat, and I see how this surgery fixes people's lives. This surgery alone. Sure, there's fusions that can be done to help too if it's done right, but why would you ever want to have a fusion surgery instead of this laser surgery? The only reason you'd have a fusion is if you weren't able to get the laser because you didn't know about it, or because it was just not something that you're able to do because you can't travel here to get it done. So, but it's our mission to teach people that their pain can be cured with the right treatment. And I've even taught this technique to other spine surgeons around the world. But they're so focused on doing fusions that they don't adopt this technology, even though it's been presented to them right in front of their face. When this was presented to me, I adopted it. I tried it, I tested it, and I saw the results were amazing. And yeah, so go figure. Why don't other people adopt it? And I know why, because they don't make as much money doing it. These surgeons, they make a lot more money doing fusions or artificial discs. But that's the wrong thing for the patient. The patient should get the very best surgery, the least invasive, the safest, the most effective surgery long term, and that's what this is. So that's why we're spreading the word.
We have a new question from
Where
YouTube.
is the other nurse?
She's on vacation.
Oh. Yeah, I'll take it.
Alright, for cervical DLDR cases, would you recommend neuromonitoring?
No, we don't do neuromonitoring for cervical DLDR cases. Neuromonitoring, I recommend for any kind of case where you're putting an implant in, like a screw or a cage, where you're working, around the nerve root. I've done now 500 cervical cases out of my 1,400 surgeries, roughly, and we've never used monitoring, not once, and we've never had a problem. I don't feel like, I'm just gotten lucky. I think that there's no need for monitoring when you're not putting implants in. That's pretty much what all surgeons agree to, by the way. Spine surgeons in general fall into two groups, those that use monitoring and those that don't. And to be honest with you, the use of intraoperative monitoring is not even standard. Most surgeons don't use it. I do, because I think it's helpful when you're putting screws in. Because if you put a screw somewhere and it hits the nerve, during the placement of the screw, you want to know that so you can take the screw out and move it. Because if you move it, there won't be any problems with the nerve after surgery. It's only when you leave it pressed against the nerve, that's when you have the patient wake up with leg problems, leg pain or arm pain they didn't have before, or weakness. So the use of intraoperative monitoring is not necessary unless you're actually putting in screws, cages, things that could hit on the nerve and stay on the nerve. So just to finish answering the question, most spine surgeons don't use intraoperative monitoring at all. And it's not the standard of care to use it, in my opinion. You can use it or not use it. But I use it because I feel that it gives an added benefit to the patient and a higher level of safety. Now, it costs us money to use it. We don't get it for free. We pay about $500 to $1,000 a case to use it, and we don't get the insurance companies refuse to pay for it. They say that because it's not standard, they shouldn't pay for it. And we fought them on it, but they don't pay. What are you going to do? Sue them over $1,000? So you basically get screwed out of the money, but we still do it because we believe it's better for the patient. So we do things here that we don't get paid for because we know it's better for the patient. Insurance companies truly don't want to pay for anything, to be honest with you. They just look for any excuse not to pay for it. But that said, a lot of surgeons won't do it because they don't get paid for it. We do it here with our instrumented cases, because we're not getting paid for it, but because we feel it's better for the patient. It's kind of like wearing a helmet when you're doing stunts, like jumping a motorcycle. Even if the people you're jumping for won't give you a helmet, you kind of bring one anyway. And most of the time you don't need it. But what if you do need it? What if you do land on your noggin? You're going to be thankful you had it. It's just that extra level of caution and care. You don't get that at most places, by the way. Now, we're still on this same disc that we've been on for the last 20 minutes, 15 minutes, And like I said to you earlier, this thing is amazing just how much internal damage there is in this disc. It's a lot worse than it appeared on the MRI, a lot worse. So MRIs can be very deceiving. If you look at the height of the disc, it looks well preserved. You don't see a lot of structural abnormality at this disc. Hey, let's get the light down one click. I think we're a little bit overexposed. But we're coming to the end of fixing this disc at L3-4 on the patient's left side. Just about done. The good thing is that once I fix this, once I fix this disc, I think she's going to do fantastic, because this was a 12 out of 10 pain. We determined that earlier with the discogram.
Doctor, do you have time for another question?
I have time.
Okay. So we have a comment on Facebook that asks, how does the dye just attach itself to the bad parts of the disc?
Yeah, how does a dye just attach itself to the bad parts of the disc? Okay, great question. So what the dye attaches to, just so you understand, let me explain it. You see that pink surface right there? That is bone. That's the end plate. It's called the end plate. It's a surface of the bone attached to the disc. That doesn't bind the dye. Bone doesn't bind the dye. And the annulus doesn't bind the dye. The only thing that binds the dye is the degenerated nucleus pulposus. So when you see blue in here, this is all scar tissue within the annular tear. That blue is not the annular tear. It's not the scar tissue. It's actually something else. And that something else is the herniated disc. So there's little fragments of herniated disc, almost microscopic, that are stuck to the tear right here that have created massive inflammation. The inflammation, on the other hand, has degenerated the nucleus pulposus, the herniation. It's caused it to degenerate, meaning break down. And it's the degenerated nucleus pulposus that binds the dye. Only the degenerated nucleus pulposus. So normal nucleus pulposus is white. Normal annulus is white. Scar tissue is white. Bone is pinkish color. So everything in here, of course, blood vessels are pink. That's fat right there, yellow. But everything in here, nothing binds to this dye except for degenerated nucleus pulposus. And what is it about the degenerated nucleus pulposus that allows it to bind to this dye? It's acidic. Degenerated nucleus pulposus is acidic, meaning it has a pH or a pKa that is acidic. Basically, it binds to basic things. Acid base. So it's the acidity of the degenerated nucleus pulposus that binds to the indigo carmine dye that we use. 10% indigo carmine dye. And speaking of which, indigo carmine has gone up dramatically in price. And I've asked my staff to find it less expensive for me. And they've been very quiet about it, which I'm not happy about. But I've got too many other things on my plate to deal with right now. We used to pay $24 a vial. Now we're at 100 and what? 40? $150 a vial. It's disgusting. The highway robbery going on. So, of course, our charges haven't gone up. We've been trying to keep our charges, affordable for people. But at some point, with the cost of everything going up, we have to pass that on to somebody, because I can't afford to pay it. But that's indigo carmine dye. All right, just about done. How's the irrigation? Good? Irrigation good. All right. I'm going to clean this up and we should be done.
Do you have time for another question, doctor?
I have time for lots of questions.
All right. Well, we have a patient that just got an MRI done
Yeah.
and has small bulges, but is disabled. Can a small bulges cause really bad pain?
Yeah, 100%. Small disc bulges are the most common cause of disabling pain. That's why we're here today. We're here to teach you that. That's the most important message we can teach people, is that it is the small bulging discs that are the most common cause of people's pain. And the good news is we can now fix them with this laser surgery. Why don't you run the video one more time? Find out if their bulges are in their neck or back.
Okay.
If they're in the neck, run the cervical animation. If they're in the back, run the lumbar animation, so they could see what I'm talking about. All right, I need 30 seconds here and I'll be done with this. And we're going to go finish the last disc. That's the end of the disc there. Just trying to clean every last bit up. I'm a bit of a compulsive person. You never want to gild the lily, but you want to get enough done so that it fixes the patient's problem. All right, looking good. Laser off. See if we can see the exiting nerve root. I think there's a little too much there. No. I do want to clean that up right there. Let me have that. Did you find out?
Yes, it's in the back.
All right, just run the video so they can see what actually causes, how the bulging disc cause back pain.
All right, doctor, we're watching the video. You are muted.
All right. You're doing great. We're almost done.
Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.m.
All right. We are just wrapping up this left side, and we're going to be taking the tube out. And just take a look here for a moment. I'm going to get this tube out. You're doing great. Just give me a second. And I'm going to show you the incision. Luis, you want to put some pressure? I'll go to the other side. So we're finished with the left side, which was 2 discs. Now we're going to go to the right side at L4-5 and fix this herniation and tear on the right side at L4-5. That will be the last tear that we fix. And, you know, every time you go to the spine surgeon, what they talk about is herniation, herniation, herniation. It's actually the tear, not the herniation, but the tear through which the herniation passes. That's the most important source of pain. And in the back and the arm, or the neck and the leg, whatever, back, leg, neck, arm, basically that is the cause of people's pain, not the herniation itself. It is the herniation, the nuclear herniation is not painful. unless it crushes a nerve root, which is rare. So all the pain actually doesn't come from crushing, it comes from the tear. That's one of the most important messages I can tell you. And you won't hear it anywhere else in the world but here, because we're the ones who discovered that. So of course, if you discover something, you're going to tell people, and people are going to hear it for the first time from the person who discovered it, which is me. But someday, probably 20 years, 30 years, 50 years, hopefully sooner, the rest of the surgeons and doctors in the world will understand what we already have learned. But it takes time to spread that information. And I have no support from anyone except my team here. And we have no, we have no financial support, no social media support. It's all just self-driven by a small company that made the discovery. So I can tell you right now, if we don't get others helping us spread the word, it's going to take a long time to change the behavior of spine surgeons and spine doctors caring for people with pain around the world. Spine pain from herniated discs. I can't do it on my own. And we have these broadcasts, which are nice, but they're limited on how many people we can reach and spread the word. Shot? All right, so this is the L4-5, and it is from the patient's right side. And the only reason we're doing this is because they have right leg pain as well. And I have to go to the right side to treat right leg pain. Any questions? Shot?
Yes, we have another question. That same patient who left the last question said he had an annulogram and it showed 4 leaky discs.
He had a what?
Annulogram.
Uh-huh.
Yes, and it showed 4 leaky discs. Can leaky discs also cause tremendous pain?
What kind of disc? I couldn't hear that.
Leaky.
Leaky?
Yes, leaky. I believe bulging.
Okay, listen. The annulogram you had done, I don't know who did it, but that annulogram that showed the annular tears, they're leaky because they have a tear. Now, if the tear is in the back of the disc, it can cause pain. But the way you find out is you do the test, the annulogram test, which is the same thing as a discogram, it sounds like. As long as it's done properly, you should be able to figure out if you have pain that's coming from those discs. So was there a report by the doctor who did the annulogram? Did they give you a report on whether or not those discs are causing pain? That's the question. And if the answer is no, that's unfortunate, they should have. And if the answer is yes, great. I want to know the results. So, did they find pain at all 4 discs? Or 3, or 2, or 1, or any? That's the real question. Whichever discs were painful during your annulogram, that should be the ones that you focus your treatment on. All right. Okay, let's show everybody. You're doing great. We're almost done. So look here. We fixed 2 discs. Can you guys see this incision?
Yes, we can see the incision.
Tiny. We got another one here, 7 millimeters. So through 2 Band-Aid incisions, we're going to get this woman's back pain cured for the rest of her life. That's what I expect. And her insurance company is going to be happy because she's going to go back to work very soon. Here, there's a little bit of herniation there for you. There's quite a bit on this exit area. All right, we are now inside L4-5 on the right side. Remember, we've already treated this disc from the left side. This is all abnormal material here. This is all damaged disc from the trauma this patient had. Laser. We need about 10 minutes, 15 minutes, doctor, and we'll be done. Say 15 to be safe. All right, for those of you who don't know, Deuk Spine Institute has Looks like the tip got fractured, guys. Yeah, we lost the tip of the laser. See it? That was before I went in. I noticed it. You just got to be careful. Yeah, it's fine. It's working, but, you know, I don't know what happened. Who beat it up? You guys got to be loving and tender. Okay? It's a piece of glass, so it doesn't bend very much. All right, so anyway, Deuk Spine Institute, we do have our app. If you go to the App Store, you can download the Deuk Spine Institute app. And on our app, you can learn a lot. There's a lot of really good information on back pain and neck pain and thoracic pain. You can have access to our video archive of spine surgeries that we've been recording and broadcasting for the last 8 years. And you can see fusion surgeries done here. You can see lumbar fusions, laminectomies, microdiscectomies, anterior cervical decompression and fusion, thoracic surgeries. I mean, pretty much all degenerative types of spine surgery is in our YouTube channel and mostly on our app and YouTube channel. Goes back 8 years. We've been broadcasting all of our surgeries from here every week live for about 8 years now. And the purpose is to educate the public, that's you, on state-of-the-art spine care, answer questions for you live, and let you participate in the treatment of patients, disc and spine diseases, see how it's done. Any more questions from our audience?
Yes, sir. We have a question on Facebook. We have a patient who has bulges from C4 all the way to C7, has seen many neurosurgeons, but they say that it is not bad enough for further treatment.
Yep. Well, we can fix them for you. So there's a patient who has bulging discs, C4, 5, 6, 6, 7, 3 of them, in pain, and the surgeons have said it's not bad enough to treat. So the reason they don't want to treat it is because the only treatment they have available for you is probably fusion, which is invasive, and they don't want to give you a fusion for something like that for pain. Number one, fusions are not recommended to treat pain. They're recommended to treat pinched nerves. And what they're saying to you is you don't have, pinched nerves, basically. Because you don't have pinched nerves, you're doing good. Because you don't have the pinched nerves, that the surgery is not warranted. And they're correct. They don't have this technology that we have. Therefore, they can't offer you this treatment. This technology is held by a few places in the world. And we're happy to teach people, but the reality is that the training process for spine surgeons happens at universities. And the universities only they've stopped the teaching of spine surgeons at the level of fusions and artificial discs. They haven't progressed beyond to endoscopic surgery. So that's kind of like fighting a modern day war with bows and arrows and spears. That's what they're doing. They're teaching the surgeons how to use bows and arrows and spears and throw rocks. We've developed a much more sophisticated, much more technical treatment that requires far more skill than bows and arrows and spears, and actually has a far greater application. Okay, so we've developed aircraft in the war scheme, and with aircraft you can do a lot. You can transport personnel, you can attack targets, you can drop supplies to where they're needed. I mean, it goes way beyond spears and slings and the type of treatments that these surgeons are using, which are, you know, older treatments that are, you know, very poor at actually treating patients' problems like herniated disc, but it's what they have. You know, do you think that when the Spanish conquistadors showed up with rifles and gunpowder and bullets, do you think that the Aztecs believed that their technology was inferior to the rifles? Of course not. They thought, hey, we got spears and bows and arrows and a few other techniques. We're very advanced. But they had no clue how advanced the Spanish were compared to themselves. And it's the same thing in spine surgery today. Spine surgeons that do fusions and artificial discs and laminectomies and microdiscectomies, they literally think, just like the Aztecs did, that they have the most sophisticated technology. And the truth is that there's a far more sophisticated technology out there. Cannons and rifles, gunpowder and bullets, and we have that here. And, you know, they don't want to stop doing what they're doing. We've never gone to war with them, and we never will, but they just keep on living believing that their technology is great and that that's what's best for you. They're people they protect, but it's not. It's really bad. Why am I getting bubbles again? Am I out of irrigation?
Rita.
Are we out of irrigation, Rita? Why are you waiting until we're out before you change it? That's like, honestly, elementary level care. It's so easy to just pay attention to the irrigation and get it before it's out. So why are we doing it this way? Really? You can't see how much is left in the bag? Is that true, Luis?
Well, the plastic is kind of difficult to see through the plastic and watch the bag. That's kind of, yeah.
Yeah? All right, let me come see.
One light?
Yeah.
See, like, there's no indication that I'm coming to the end here. It's under pressure, so
What is that writing?
this here, that's
Yeah.
ComEd. That's the ComEd.
And where is that writing located?
On the outside,
No, the green writing.
oh, that's it inside the bag.
Let's see.
But there's no, like, warning that I come close.
But you see that opaque membrane? So what I would say is I've got to get you to do that, Rita. If you can't do it, then we can't let Crystal go on vacation. Does that make sense? Because if you can't do it, then I've got to have somebody here who can. It's that simple. I'll let that sink in. Okie dokie. Diego, you got any more questions for me?
No more questions, doctor.
All right. Why don't you go ahead and run the video on what it is we're actually doing here. The animation, so people that have come in late can actually understand what the Deuk laser disc repair surgery is all about, why it's revolutionary and different. Let's have the grabber.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc.
All right, I was just talking about the age of this disc injury. It does look like it's very consistent with the age of her work injury to her back. And she said she injured her back 2.5 years ago. I would say this injury does look from inside the herniation like it is about 2.5 years old. We don't have a lot of the really dense scar tissue that you see with older injuries. You don't have any of the calcifications that you get with the older injuries. So it is definitely, in my opinion, consistent with an injury that's around anywhere between 2 to 4 or 5 years old. So it's consistent with her history of a work-related injury to the disc. Just about done here at this disc. There's just a lot. Once again, a lot of damage. This is all part of the tear. Do you have the scoring device, Luis? Do you have the scoring device?
The scoring device, yes, sir.
You want to try it? It's sterile, right?
Yes, sir.
So what I'm working on, for those of you who don't know, we are literally inside the annular tear and the herniation. The herniation came out through the annular tear. We went in through the annular tear. And we even shoved some of the herniation back into the disc itself, which makes it easier and safer to take it out. You ready? Laser off. Light on. Light on. I'm going to try to score this end to make it a little better. Because the end of the glass has been fractured, and it didn't fracture inside the patient, it happened on the operating surface of the table when we had taken the fiber out of the patient. That fracture is irregular surface, So it's distributing the laser energy in an irregular pattern. And I'm hoping, you cut the glass too, right? And I'm hoping that by rescoring it, that it's going to be a bit more efficient at delivering that energy to the patient. Let's see if we have an improvement in performance. I don't know. It looks better, yeah. Yeah, it's definitely better. Yeah, because of that irregular glass surface, it was just shooting the beam everywhere rather than straight down. And that has definitely improved the performance. Just about done, I think 5 minutes, I'm hoping. How is she doing? Good. It's good to hear. It's that lateral herniation I talked about earlier. Here, laterally. Just so much more damage than you would pick up on the MRI. Just shows you can never really tell how much damage there is inside the disc till you get inside the disc. The MRI doesn't give you an indication. The discogram that we did shows pretty bad disruption. So that could have given me a bit of a clue, which it did. You could see how abnormal the inside of the architecture of the disc was on the discogram if you go back and look at it. It wasn't a normal looking disc on the inside. Some of our disc herniations have a relatively normal center part of the disc. This one was more irregular and abnormal in the center. See that little herniation there? How are we doing on irrigation? Good? Let me have a grabber. Getting better, Flynn.
Yes, sir.
That's what it's all about, improvement. Right, Luis? Luis will tell you. Nobody comes in knowing everything. It's all about improvement. Some people are limited in how much improvement they can achieve. Other people have more capacity to learn and do better. It's not a physical limitation, it's a mental limitation. My Lord. Our next patient is a cervical laser, is that correct? So for those of you watching, the next surgery will be done on the cervical spine. This patient we put first. Normally we do cervical spine surgery first, but this patient went first because she had, I believe, been canceled a few weeks ago. So we wanted to accommodate her and get her done first. Grab her, wipe that tip. Neat. Well, everyone's disc takes different amounts of time to fix. Some of them more than others, and this is one of those longer ones, which is fine. You can see when I put the grabber down, it really didn't grab out much of this stuff. And that shows you that everyone talks about, oh, lasers, you don't need it. You know, these spine surgeons that don't use the laser are the first people to say lasers are unnecessary in spine surgery. But you could see the traditional grabber instrument, the only other instrument that could even work in here, doesn't work. And so you really need the laser. And surgeons that say, oh, the laser doesn't do anything, they're ignorant. And they're lying. They're lying to themselves, they're lying to you. They just either don't know and they're just making it up, or they know and they are lying. But the laser is probably the most powerful tool that can be used endoscopically. There is another tool, but it's less powerful. It's a radio frequency probe. Look at the blast marks on the metal there. You guys see them? Look at the metal wall. Look at all that melted steel. Guess what melted that steel? The laser. So when you tell me that lasers aren't powerful, they can't be used to take care of bone spurs, it's not true. It's just people that don't know because they don't use the laser typically. So they don't know any better. Or they're, you know, just full of it. Either way, it's misinformation. And that's what we want to fix here in spine, is the misinformation that's out there. There's too much of it. Too much misinformation. People need to know the truth so they can get the best care possible. All right. I need just another minute, I think, and we'll be done. How's she? Good. Okay. The ideal patient, right? Mm-hmm. Okay. Yep, I think that's a great idea. By the way, the propofol we use, a lot of people don't know this, but the medicine being used to put this patient asleep is propofol, and propofol is not a painkiller. It is not a painkiller. Take that. Let's have the grabber. So when patients wake up from the surgery, and they have none of their pain from before surgery, it's not because of the propofol. It's not because of something we gave them. God, it's just a pain in the butt getting all this out. Luis, I'm unable to rotate the fiber. All right, just about done here. 30 seconds and we'll be wrapped up. Any more questions from the audience? Diego, why don't you type your questions up, folks? I'll come and answer them for you face to face. In the meantime, let's talk about, Diego, the alternative, spinal fusion. Let's show them a video that will show them the spinal fusion versus the Deuk laser disc repair.
Okay.
So they can understand
Deuk laser disc repair.
how the Deuk laser disc
Comparison
repair
with
is.
traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone.
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the form. Things to remember when submitting your free MRI review. All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute.
Dr. Deukmedjian here at the Deuk Spine Institute. We're just finishing a lumbar Deuk laser disc repair on a patient who she injured her back at work, blew out 2 discs. The L4-5 blew out on both sides. The L3-4 was blown out on the left. And when we got in there, the discs were damaged far more than the MRI had shown us. So it was worse than expected, took longer than expected. And my back is hurting now from doing the surgery. But no, in all seriousness, the surgery went really well. Didn't have any complications. I expect that she'll do quite well. I expect her back pain to be gone, her leg pain to be gone, and her to go back to work very soon. One of the advantages of this surgery you just watched, the Deuk laser disc repair, is an immediate return to work, usually within a day or two. Some people want to take a week off, and that's fine. But there's no long, protracted recovery like you get with spinal fusion surgery or microdiscectomy. Those types of surgeries, laminectomy, microdiscectomy, any open back surgery that any other surgeon will offer you is going to take weeks, if not months, to recover. And you will be taking powerful prescription, opioid, narcotic pain medication every day, trying to stay out of pain. Why do people have so much pain from open back surgeries? Because of the damage that's done under the surface, what you can't see. That surgeon has gone in there and destroyed your muscles. You'll see that 6 months later on your MRI with scar tissue everywhere. They've drilled holes in your spine that you can't see from the surface, that have weakened the spine. They've torn out ligaments in your spine. So all that internal damage to your body from open spine surgery like fusion, artificial disc, microdiscectomy, laminectomy, pretty much every other spine surgery in the books out there that's being offered to people all over the world, those types of procedures do massive internal damage. That's why there's so much pain after surgery. Our surgery doesn't do any internal damage, which is why people take Tylenol and a muscle relaxer for one time that night of the surgery, and then by the next day they're off their medications usually. All right, we have a question. I'm going to answer it for you.
Okay, we have 2. First one is the guy from the Lumbar. He says, you know your shit, cannot wait until you work on my many issues. This patient will have a great Thanksgiving and Christmas because of you.
Oh, good. So one of our viewers who is scheduling surgery with me is excited about their surgery, looking forward to the surgery and getting better. So I am too. Yeah, thank you for that. I really appreciate it.
Okay. And then we have one viewer. He or she has been pretty confused about what does bulging, degenerative, and herniation mean?
Yeah, it's a great question. So I'm going to do my best to explain this one. Let me see what I can do here. So this viewer is asking the million-dollar question. What's the difference between a bulging disc, a herniated disc, a degenerated disc? And I'm going to tell you right now, because I've explained this before, but it's worth talking about again, because there's so many people that want to know, and it's really important. And you won't hear it anywhere else. All right. The disc, and why so much talk about a disc? The disc is the most commonly injured part of the spine, okay, by far. Injuries that happen to the spine, and the spine, by the way, is the bones and a cushion between the bones, and of course the joints in the back, and then the ligaments that hold everything together. You can't see the ligaments here because they didn't put it on the model, but basically the parts of the spine that can be damaged are the ligaments, the bones, the disc, and of course what the spine protects, which is the nerves. So most pain in the spine, like literally 95% of the pain in your spine, comes from the disc, okay, the disc, injuries to the disc. So let's take a look at this disc. I'm going to take the disc out and show you what I'm talking about. So imagine I take this disc out. The first thing you got to notice is something called the height of the disc, which is the fatness or top to bottom size of the disc, okay? And the disc is really made up of jelly in the center, and that's what gives it its height. And then it's got a wall of cartilage, not cartilage, but collagen around the jelly that holds the jelly in place. So the jelly can't escape, okay? And the problem happens, I'm going to use this one here, it's a little better. The problem happens when you have an injury to your back. Of course, my team has hidden my toys, my toothpicks. The problem happens when you get an injury to the wall of the disc called the annulus fibrosis. The injury is essentially one injury. It's the only injury that happens. It's a tear. The annulus tears. It literally holds the jelly in, and then it rips with trauma, like a car accident or a fall or some kind of sporting injury, water skiing fall, gymnastics, golf, whatever. You rip the disc, the wall of the disc. And when that rip forms, now the jelly in the center that's been held in there by that wall, the annulus, it has a place to go. And the next time you go to pick something up or bend over or twist, you put pressure on the bones, they squeeze down on each other, they load, load down. I'm going to show you. Give me a second. This is a pretty cool model that I actually designed years ago. When you load the bones, like you stand up and lift something, you're pushing down and you can see that the jelly squeezes out. I'm going to show you what I'm talking about. Right through that little window there. Yeah, you point to it. The jelly actually pushes out. Can you see it? Mm-hmm. Yeah, it's kind of hard for me to see, but that's what happens after you get a tear. So anytime you bend over, pick something up, lift something, the jelly pushes out. Okay, that's called a herniation. So when it's a small herniation, it's called a bulge. When it's a bigger herniation, it's a herniation. But a bulge is a herniation. The term herniation means to have one tissue, which is your center jelly, pass through another tissue, which is the tear in the annulus. The movement of the jelly through the tear is called a herniation. And there's really two distinct herniation locations. One of them is the herniation that's stuck in the tear, and the other is the herniation that comes out of the disc. All right? And the problem is that when the herniation comes out of the disc out here, that's when the radiologists call it a herniation. But a herniation that's contained is called a bulge. So it's just a matter of, how far it's escaped. The jelly has escaped. But it's really the part that's stuck in the tear that causes all the back pain. So annular tear, small herniation is a bulge, bigger is a herniation or extrusion. And then, of course, what is degenerative disc disease? Well, when you get that jelly stuck in the tear, it creates inflammation. Your body is attacking that jelly, trying to get rid of it. Reason for that is the jelly that's in the middle of the disc has never seen the blood supply of the body because the center of the disc has no blood supply, so there's no blood vessels. So guess what travels inside your blood system? Well, it's your inflammatory cells, like your mast cells and your polymorphonucleocytes and your macrophages. Those cells make up the inflammatory system. And once this jelly sticks out into the outer annulus where there's a blood supply, suddenly it's exposed to your inflammatory system, which is floating around in your blood vessels, and it can see that stuff and it goes, whoa, stop, reverse, what the heck is that? That shouldn't be there, attack. And pretty soon you have inflammatory cells being called from all your body to go to this one little spot and fight the jelly, because your body thinks the jelly is a foreign invader and it shouldn't be there. It thinks it's like a rock or a stick that's stuck in your body, something that shouldn't be there. So it creates an attack mode and starts to destroy that herniated fragment. Well, that inflammation goes on for years, and the longer you let it go, the more years you let it go, the more it destroys the jelly of the disc, the whole disc, because that inflammation spreads to the whole disc, and the disc starts to collapse. This is the first place in the world you'll hear this. There are scientists around the world, top scientists, doing research on discs, trying to figure out why do discs degenerate. They don't know. Well, we know. It's because of the inflammation going on in the back of the disc, in the tear. That is what's causing degenerative disc disease. It causes the disc to collapse over time. So when you have a tear and you have inflammation, it's causing pain. get it fixed right away with the Deuk laser disc repair. It's the only surgery in the world that fixes that tear and that inflammation. When you get that fixed, it stops the inflammation, the disc stops degenerating. It's a long explanation, but that is the most accurate, up-to-date, current knowledge that we have about herniated disc, bulging disc, and degenerated disc. Any other questions? All right, I think we're done, and we'll be back shortly with a 3-level cervical Deuk laser disc repair.